I've been a VODR-trained lymphatic therapist for 23 years, working in Alberta. And I've been recertified back in Austria about 6 times, I guess, during that period of time. So we've seen a lot of lymphedema patients, but we also see a lot of lipedema patients because in Canada, in Alberta, and really in North America, there's very little understanding of lymphatic disorders and some fat disorders that lead to lymphatic disorders. So probably many of you have found this frustration in your own lives that your doctors really don't know what's going on for you, and you repeatedly see doctors who don't know what's going on for you. Stanford University actually did a study about 3.5 years ago, looked at 140 medical schools in North America, and found the average physician had less than 20 minutes education on the lymphatic system. So that probably pretty much explains why we're where we're at. So, you know, in 23 years of advocating for understanding of the lymphatic system, it's only been in the last 6 years that we've really made some progress. And what happened at that time was we got involved with a couple of philanthropists named Burley and Diane Kipnis, and we started a specialized clinic in Edmonton treating lymphatic disorders from a clinical perspective. I'm not a physician. And we also began to undertake some research initiatives that, in my view, would capture the imagination of the medical community. And I'm now co-leading a project between the University of Calgary Faculty of Medicine, the University of Alberta Faculty of Medicine, the National Institute of Nanotechnology, and the Human Metabolomics Project to make Alberta one of the leading research locations in the world in lymphatic disorders. And we've really made some strides here, particularly in Calgary. But in order to begin to understand why we need to talk about the lymphatic system and lymphedema when the issue we're dealing with today is lipedema, I'd like to give you a little bit of understanding about the anatomy and physiology of the lymphatic system. And I'm not going to go into it in great detail, but you do need to understand a little bit about it in order to appreciate why the conservative treatment is able to do what it does and why it's not able to do what it doesn't do. So the first thing we're going to start with in the presentation is a look at the lymphatic system anatomy and physiology. And I want to talk a little bit about the transition from lymphedema to lipedema and some of the factors and mechanisms, the consequences of lymphatic dysfunction, and then some of the lipedema management techniques that we use on a conservative basis, and then a little bit of look at what the future holds. The lymphatic system is basically the sewer system of the body. Okay? It moves pathogens, antigens, dead cell particles, large lipids, and large proteins from our extremities to the subclavian vein up around our collarbone. It's very different than the vascular system in that the vascular system is a closed circuit system. It circulates through the heart and back through. The lymphatic system, on the other hand, takes fluids and debris from the distal areas and moves it into the vascular system. So it's a one-way system. Our body's divided into different watersheds. So the back of our legs, for instance, drain to the front of our legs, which then drain up into the inguinal area, go deep into the pelvic and abdominal collectors, through the thoracic duct and up into the terminus. The arms drain into the axillary areas, the head and neck drain down into the terminus. If you imagine it like different fields. So if you get situations where you've got blockages in those lymphatic pathways, there's nowhere for the fluid to go. But with some of the conservative techniques, we can move that fluid, for instance, in the leg from medial to lateral and up over the navel lumbar line at this level, where it gets picked up by healthy lymphatics up in the upper body and drained into the axillary areas. What does it look like? This is a picture of the initial lymph vessel. It's single layers of what's called endothelial cells. They got little filaments that hold them together, and they stick up towards the top of your skin. This would be the top of the skin. And they sit there like fingers in a glove. And they attach then, these are the mass of initial lymph vessels, and they attach to pre-collectors and then into collecting vessels, which are wrapped with smooth muscle. What the lymph system does is it maintains fluid balance in the body. So 100% of your fluid in your tissue returns to your circulatory system through the lymphatic system. And it does so on the basis of about 3 to 4 liters a day into the subclavian vein and another 3 or so liters a day in around your lymph nodes, which means about 7 to 8 liters a day of fluid moves back into your vascular system from your tissue. The other thing is that it's basically the transportation component of the immune system. So anytime you get a virus or pathogen of some kind, it gets picked up by the lymphatic system and moved into the lymph nodes, where B and T lymphocytes identify what those pathogens are, begin to multiply and kill it off. So it's got a really important role with respect to our immunity. And it also transports absorbed lipids or fats from the small intestine. Now, there's a lot of information on here, but it's a little hard to see at the top. It says lipedema, chronic edema, lymphedema, and lipolymphedema. What I wanted to talk a little bit with this slide is that different types of swelling or volume have different causes and reasons. Lipedema, for instance, is a lifelong chronic progressive debilitating disorder. Chronic edema is defined as being swelling that's around for more than 3 months, but it's not a lifelong situation at this point. Lymphedema is in fact a lifelong chronic disorder. There's no cure for it, as is lipolipedema. Now, what happens here with lipedema is that they're not sure what causes the fat metabolism to behave the way it does, coupled with chronic pain. But over time, the lymphatic system begins to diminish in terms of function, and you get a diminished lymphatic function through all of these areas. Any one of these can cause the lymphatic system to be diminished in terms of its function. The important thing about this slide is that the tissue protein levels are different in these different disorders. In an early stage lipedema, there is a low interstitial protein content. That means that the protein outside the vascular system, in and amongst your cells, isn't any higher than it is inside the vascular system. But as this lymphatic function begins to be impaired, the protein level rises. And that's the same is true with chronic edema. There's a low protein level. But when you get into a lymphatic dysfunction, you start to get into high protein levels. Now, why that becomes important is that we always talk about lymphedema or lymphatic disorders in terms of being swollen. We're always focused on the fluid. But the issue is not the fluid. The issue is the protein. Because the protein, when it becomes higher in concentration in the interstitial tissue areas than within the blood vessels, fluid runs out of the blood vessels into the interstitial areas in order to balance the concentration levels, and people swell. And they will continue to swell as long as those high protein areas exist. Factors that affect lymphatic flow, obesity. The recent statistics that I just saw out of the US suggest that obesity is now the leading cause of lymphedema in the United States. It's superseded cancer as a result of it. Up until recently in North America, we've said that the leading cause of lymphedema in North America is treatment of cancer, surgery, and radiation. But it's now been taken over by obesity. Cardiac or venous insufficiency, where you don't get your blood flow back out of your legs. Cardiac obstruction as a result of the obesity. Immobility, the ability not to get around as much, sitting more, not being able to be as active, sedentary lifestyles. There's genetic predispositions to lymphedema. There's basically two kinds of lymphedema. They talk about primary lymphedema, which is congenital, and Stanford University has identified about 5 genetic factors for lymphedema. There's also inflammation, burns, surgery, radiation, node dissections. Scar tissue formation, fibrosis, and adhesions is another one I think that is relevant to the discussion of lipedema. As you get untreated lipidemas, you develop more scarring, as Dr. Stutz has shown us, and it results in more fibrosis and more lymphatic dysfunction. There's recent research that shows that talks about the early intervention in obesity to reduce the amount of lymphedema that's occurring. A study in the New England Journal of Medicine showed, in fact, that all patients with a BMI higher than 59 had lymphedema. It appears that it's probably, the magic figure is probably around 53, 54 BMI, when everybody under 54 BMI in their study had no lymphedema. Everybody basically above it, above 54 they began to see it, and then above 59, everyone had it. The other thing that's important to note is that obesity-induced lymphedema is non-reversible. So once you get it, you got it. So it really underscores the importance of intervening early and managing the situation. What are the signs and symptoms of lymphatic dysfunction? Chronic swelling. Your feet swell, your ankles swell. You know, you may have had lipedema and your feet were never swollen before, and now you begin starting to have trouble with your feet swelling. At first, they'll swell for a little bit, and then they'll go down. If you elevate them over time, they don't go down anymore, starting to indicate you've got a lymphatic dysfunction. With lymphedema, there may or may not be pain. It's not like lipedema where there is pain. So one of the distinguishing features at the clinic that we'll use in terms of determining whether or not somebody's got lipedema or lymphedema is that their feet aren't swollen, so they've got a negative Stemmer sign, and they have no pain in their legs, or they have pain in their legs. You'll get some sensation deficits, you'll get some restricted range of motion due to the volumes. There's a weakness, heaviness, tightness, fullness, especially in the legs, but if it affects the arms as well. People with lymphedema have body image problems, they have daily living problems. There's actually 4 different stages of lymphedema. There used to be, until a few years ago, 3 stages, and then they added stage 0, which we've been able to identify with bioimpedance devices that there's a difference between the swelling or the fluid inside a cell and the fluid outside a cell. So you can actually distinguish with that device people that have lymphedema before they show any signs or symptoms of it. Right now, the way in which you diagnose lymphedema in this country is a case history and a tape measure. So it's a pretty crude approach. I was sitting in a meeting with an inorganic chemist who couldn't quite wrap his mind around this because he was attaching inorganic particles to neutrophils in order to image deeper in the body, and he was going, let me get this straight, a tape measure? Stage 1 lymphedema is, you can see it in these 2 arms. There's slightly more swelling here. It's diminished by elevation, so if you put your legs up, your feet up, and they go back down, you may only be at stage 1. And when you push a finger into an area and the indentation stays there, it's called pitting edema. It's indicative of stage 1 edema. Stage 2, what happens is you stop reducing when you elevate. Gravity no longer matters. And you may or may not have pitting. You can see you get a larger limb volume in this case. With stage 3, what begins to happen, and here's stage 3 down on the bottom, you begin having tissue that becomes hard and fibrotic. It's no longer pits at all. It's leathery, it's hard, you get skin changes, you start having fat laid down in those areas. There's warty overgrowths, there's hyperpigmentation, you can see some discoloration of the skin. There's skin changes such as thickening. This is an interesting little dissection that was done. Here's a stage 0 lymphedema, and this is a lymphatic vessel actually that was dissected. And it looks relatively normal. It's got a normal diameter, normal thickness of the cell walls. And you can see that there's not much really any difference between this woman's 2 legs. In stage 1, you begin to get dilation of the lymphatic vessel itself. And here's a cross section of it where you get some thinning of the cell walls somewhat and a more dilated, larger vessel. And that's, not a significant amount of swelling to see that kind of a change. In a stage 2 lymphedema, you start to have a lot of sclerosis and development of fibrosis around the cell wall, and you've got a much smaller diameter within the lymph vessel itself. So, you go from this situation where there's a lot of dilation to this situation where there's a lot of restriction. And when you get into a stage 3 lymphedema, you get into very little gap at all in there and very thick cell walls, and they aren't functioning any longer. We have stage 3 lymphedemas in Alberta, particularly in rural areas. I find it absolutely amazing in this day and age that we aren't particularly good at dealing with this at this time. There's consequences of chronic lymphostasis. You get protein-rich interstitial edemas, you get fibrosis developing, you get increased infection rates. People get a lot of cellulitises when they've got lymphatic dysfunctions. You get a lot of changes in vasculature and vessel walls. A lot of these are fancy words for your ligaments and tendons aren't doing very good. The conservative treatment of lipedema, when we talk about conservative, we're talking about it's non-invasive, it's not surgical. It's determined by the site, stage, complexity of the situation. Everybody's situation's a little different. There may be or may not be comorbidities, other things going on. They may or may not be obese. They may or may not have problems in terms of their renal function or whatever. We also have to look at the physical and psychological tolerance for treatment of the patient. Being wrapped in short stretch bandages every day and wearing compression on a daily basis is not an easy gig. So it takes some real effort to go through. We have to look at the client's social situation and what we're trying to achieve. The intensive or reductive phase happens one of 2 ways in Alberta currently, and primarily it's happening as a result of compression therapy. So most of the clinics that are around are wrapping, often with Coban 2 or Comper 2, and they're basically coming in daily, wrapping the limb. It goes down, they wrap it again the next day. It goes down, they wrap it again the next day. Now, that's getting the volume down in most cases, although there are some people that don't do very well at that. What it doesn't change, however, is the protein concentration level in the interstitial fluids. So the protein's still there, even though the volume's down. So the fluid's still trying to get out of the vascular system. And so you see about 30% of people failing with compression therapy alone. The other is combined decongestive therapy. And manual lymphatic drainage is the primary difference between combined decongestive therapy and compression therapy. And what that is a gentle rhythmical massage. it's very superficial, in that 70% of your initial lymphatic vessels are in the top 2 layers of your skin. So if you compress the tissue more than the weight of a nickel lying on your skin, you've got too much weight and you're just pushing fluid in and out of the lymphatic system. You're not actually moving fluid. MLD can increase lymph flow from a resting state of about 6 to 10 pulsations a minute up to 10 to 30 pulsations a minute. So we can increase lymphatic flow up to 10 times normal levels during a session. And that'll diminish back down to normal levels over a 24 to 36 hour period, which is why we like to see patients daily and do the massage and then wrap them, and the next day see them again, do the massage, wrap them. Because now we're moving protein and fluid out and reducing with the compression. There's a variety of studies on the effectiveness of CDT, combined decongestive therapy. The problem with them is that most of them don't control the MLD methodology. So when you look at these studies, and some of them have actually been done in Alberta, they say, there's only a 6 or 8% increase in the reduction of fluid volume using combined decongestive therapy as a result, as opposed to compression therapy. What they haven't done is control the methodology and how you do the MLD. So are you talking about, gentle effleurage on the skin, or are you talking about a Vater or Foti technique in terms of actually doing the reduction? And so most of them have not been peer reviewed, they haven't been controlled, and they're not done. This is an interesting one with respect to lipedema. There was a study done by these folks on 38 women with lipedema, and they found that, in fact, manual lymphatic drainage and intermittent pneumatic compression reduced not only the leg volume, but it reduced how fragile the capillaries were, and it reduced the pain intensity in patients with lipedema. One of the things that we find with lipedema patients when they come to the clinic is they often can't tolerate compression. So you usually have to start with lighter compression with them. But one of the things that we do find consistently is that manual lymphatic drainage reduces the pain, and then they are able to tolerate compression. And so then we can get the fluid volume down that is accumulated in the areas. Now, we can't do anything about the fat. Nothing changes from that perspective, and that's why a conservative approach can only take you so far. And until recently, with Dr. Stutz's approach with liposuction, there wasn't really any good alternatives to that. And we've actually seen in our clinic quite a number of patients that have gone through liposuction that have been done by cosmetic-oriented doctors and skin reduction techniques that have actually, in my view, caused lymphodemas. So manual lymphatic drainage, the goals include stimulation of the lymph flow, reduction of pain, sensation of heaviness, a reduction in inflammation, a removal of fluid and waste from the tissue, and a diversion of the fluid away from the areas of congestion. So if it's the legs that are swollen, for instance, we'll move the fluid from medial to lateral and then up over the navel lumbar line, where it gets picked up by the healthy lymphatics in the upper body. The technique, it's light, it's rhythmical, it's gentle. There are some contraindications, however, if you've got any severe kidney disease, if you've got uncontrolled congestive heart failure, acute infections, DVTs, or untreated cancers, manual lymphatic drainage is contraindicated. The reason for that is when you can stimulate the lymph flow by up to 10 times normal levels, if somebody's got an acute infection in their foot and I stimulate their lymphatic system, we now have a systemic problem, which underlies the importance of getting a therapist that knows what they're doing. You also want to make sure that they know properly how to drain the leg. I saw a gentleman from South Carolina who had gone to a therapist with 1 week's training in a hospital in Florida. He had a swollen limb as a result of prostate cancer. They reduced the size of his leg, but they gave him a scrotal edema. So now he had a genital edema where the scrotum was about this size. He was not happy camper. There are some studies that have actually shown that MLD increases the contractile function of the lymphatic system, and we've used infrared imaging to show that, and it basically shows that volume reductions in the order of 67-68% of the lower extremities and 59% in upper extremities as a result of manual lymph drainage, and that it increases in both healthy and lymphedema patients. So not only can you do that with somebody whose lymphatic system functions well, you can do that with somebody whose lymphatic system doesn't. I worked on a woman one time. She'd been 30 years with a swole, huge arm after breast cancer surgery. It was hard, fibrotic. Within 10 treatments, 10 days, we reduced her arm by 50% of her volume. And nothing had been done to it for 30 years. So the body has an amazing ability to regenerate those kind of things. We also know, as a result of this study, that MLD reduces cytokines and chemokine levels. What that means in normal terms is that it reduces inflammation, and that it in fact moves those agents into the lymphatic system and out of the area. Compression, currently in Alberta, compression is the most widely used treatment for chronic edema and lymphedema. Clinical experience shows that many lipedema patients struggle to tolerate compression, and that it's primarily used in the reductive phase, but once you get the reduction down, then you need the garments in order to keep it down, otherwise it just goes back up. There's basically 3 bandaging approaches in a conservative treatment, whether or not you're doing CDT or you're just using compression therapy. And that short stretch bandages, you might have seen them, that you can't pull them apart very far. They've got a high working pressure and a low resting pressure. You've got long stretch bandages that are more similar to the tensor bandages we have over here, which are a complete waste of time if you want to use them for reducing edema. And so is 2B grip. Don't let anybody put it on you for that purpose. The other one is Coban 2. 3M came out with this product a number of years ago, and they've been pushing it really strongly ever since, and you'll see it used a lot in Alberta right now. Intermittent pneumatic devices, they originated in the 50s, and segmental compression began in the 70s, where they would squeeze first at the bottom and then part way up and then at the top. They've gotten much better now. There's a product out called FlexiTouch out of the US, which they took a Vater MLD therapist, and then they mimicked the pressures of the hand in the direction of the flow of the therapist, and then they built this sleeve to mimic it. They've actually shown some good results in terms of 88% reduction in limb volume and 86% reduction in fibrosis, reduction in pain, increased range of motion. What they haven't been able to show, however, is that any of the macromolecules, i.e. proteins, are being transported out of the tissue. So just the thigh-high ones, if they're used as a standalone therapy, I'm not a big advocate of. Because what that does is it takes all the fluid in the tissue and it moves it up to the top of where the pump is. And then all the protein stays there. And I always like to say, when protein hangs out together, it likes to hold hands. And it becomes fibrotic. And so you get this fibrotic cuff at the top of the garment, of where the limb is. And then you've diminished the lymph flow even more than you had before. So especially some of the early compression devices weren't that effective. Now the series depends on a variety of things: the treatment approach, the length of the session, the number of treatments required, the severity of the edema. Intensive protocol usually goes 10 to 14 days. It doesn't with lipedema patients. I very rarely work on them any more than daily for 5 days because you get such good reductions. We're always getting asked what the results are, and I really hate this question in some ways, and I know everybody's interested in it because it has cost implications and it inconveniences your life, but you know, how good are the results going to be? Well, that's going to be based on the physiological condition of the individual we're dealing with. It's going to be dependent on the extent of lymphatic damage and how compliant the person is. As I said, being wrapped daily, coming in every day for MLD is not an easy gig. So if people start taking their compression off in the evening or during the night or whatever, it kind of messes up the process a bit. What we do know is that we have been successful in providing edema reductions and reversing tissue fibrosis. As I say, I've been at this for 23 years, so we've seen a lot of patients that way. Some clients have experienced complete reductions in their fluid volumes. Well, that's not the norm. At our clinic, after a single CDT series of 10 to 12 days, we usually see a reduction, on average, about 63% volume reduction. But we range anywhere between 8.5% and 100%. Okay, here's an important one. How do you find a qualified lymphatic therapist? In Alberta particularly, there is no regulation limiting who can call themselves a lymphatic therapist. And that doesn't mean just with respect to massage therapists, but it also is the case with PTs, with physical therapists, with occupational therapists, with nurses. Anybody can say they do lymphatic therapy. We've tried to address that issue, and what we've done is we've said, okay, first off, you need to have a license in one of these areas in order to do it. And then we adopted the LANA standards, or the National Lymphedema Network standards out of the US, which says you need 135 hours minimum CDT training after you're already a nurse or a PT or a massage therapist or something. You can find therapists in Alberta actually on the Alberta Lymphedema Association's website. They've got a listing of everybody that's qualified in the province right now. Here's some things that you can do to minimize the risk of developing lymphedema. Taking good care of skin and nails, really, because I don't want people at risk for infections. Eating a balanced diet, avoiding pro-inflammatory foods, eating anti-inflammatory foods. You need to move, exercise. I'm a big advocate of aquasize, especially for lipedema patients. Get in the water. When you're neck deep in the water, the compression that you've got on your lower legs and foot is actually higher than any compression garment they can put you in. This is probably an important one that you're all much more aware of than I am. The quality of life of lipedema and lymphedema patients diminishes as the disorder gets worse. We see a lot of decreased self-concepts. We see altered limb functions and mobility, pain, discomfort, depression, anxiety, occupational restrictions. People don't socially participate as much as they used to. So it's not just that it's a physical manifestation, there's a psychological and an emotional manifestation of all of this that is really important. Okay, what's the future hold? There is hope. We're seeing more surgical interventions in the area of liposuction, which is lymph sparing, which we haven't seen in this country until, I still don't think we're seeing it yet, to tell you the truth. There's some doctors, one in Calgary and one in Toronto, that are starting to do lymph node transplants with lymphedema patients. Unfortunately, the stats on that at this point are 50% of them fail within the first year, so they're not really good at it yet. There's some lymph vessel transplants. I had a patient go to Germany, actually, in Munich, and they transplanted 2 lymphatic vessels, each the size of a human hair, from her right leg to her left leg. And 6 years later, that transplant is still working. There's improved diagnostic testing on the horizon with near-infrared imaging. We're actually talking about getting a couple of machines in Alberta, in Calgary and in Edmonton. Lymph scintigraphies, they're not widely used here, but we're getting more and more doctors that are prepared in situations that warrant it to actually get lymph scintigraphies. Bioimpedance devices, which can measure fluid volumes. We're seeing increased research initiatives. We've got great research going on at the University of Calgary right now in cooperation with the U of A. Stanford's looking at identifying genetic markers. We're doing a lot of work on identifying biomarkers so that we can find what we're really looking for is a biomarker that we can use diagnostically, and we're moving along in that area. We're attaching nanoparticles to live cells so we can image things deeper in the body than we've ever done before. And there's some drug trials actually going on right now at Stanford with non-steroidal anti-inflammatories to promote lymphatic vessel growth. So there is a lot more hope now than there was 23 years ago, let me tell you. There's a lot more attention being paid to it, and I think the future looks pretty bright, actually. Thank you very much for your attention.